So, welcome to the lecture on decision-making in localized and locally advanced prostate cancer. The decision-making in prostate cancer is difficult because there are alternatives available, particularly in the management of localized prostate cancer. There is uncertainty about the biological potential of a localized prostate cancer, in which decision-making becomes quite complex. For aggressive cancers, there are high-risk consequences. So if your decision-making is not appropriate, it may go into a situation where you probably will not be able to retrieve. Then there are interpersonal issues, because quality of life is an important parameter in the management of prostate cancer. There are consequences related to erectile function, consequences related to incontinence, and both of these factors can have a significant impact on the life. Treatment itself is quite complex, be it radical prostatectomy or radiation therapy. So all these makes the decision-making in prostate cancer quite difficult. So I'm going to take you step by step in the management of prostate cancer and see how decision-making can be facilitated. Well, why prostate cancer is different from other cancers? And I think that's something that we need to understand, and that's critical to the management decision-making. Well, this is an important paper by Kimura and colleague published last year in Cancers. And you can see that there is a significant proportion of prostate cancer which is latent prostate cancer, which means that these are detected in autopsies performed on patients who have not died of prostate cancer-related complications. So they've died of something else, and they were harboring prostate cancer. And over the last 60 years data, you can see that significant proportion extending from 55% to about 15% is latent prostate cancer. Now, after 2000, this is impacted significantly by PSA-based screening. PSA-based screening has increased the diagnosis of insignificant prostate cancer. So obviously that has decreased the prevalence of latent prostate cancer. So something which was lying silently is being detected, and then we'd start making decision about how to manage that. If we look at the data about pre-PSA and post-PSA era in the prevalence of latent prostate cancer, we see that the decreased in the incidence of latent prostate cancer after the PSA era is threefold. So significant drop in the, and this is reported in Journal of Urology some years back. So clearly, in terms of prostate cancer, we are over-diagnosing cancer. And I've looked at the definition of cancer in Dolan's Medical Dictionary, and it's obviously is a neoplastic disease, the natural course of which is fatal. And this is what happens when you mention prostate or cancer, the word cancer, to a patient, that he immediately becomes quite defensive and start thinking of dire consequences. However, in prostate cancer, this is not entirely correct. So a paper by Welsh and Black in Journal of National Cancer Institute, and in which they have looked at what is overdiagnosis. An overdiagnosis of cancer is a cancer which is detected, which would have otherwise not caused any symptoms of death. And why these cancers would remain latent is because these cancers either would never progress, or they would progress so slowly that the patient would die of competing causes rather than of that cancer complication. The cancer diagnosis at the time of detection is also very important. And we know that some of these cancers, which are biologically silent, they would probably lay there and would not progress. Whereas some of these cancers can obviously have a significantly high growth rate. It's also important, that's why that the 10-year life expectancy is an important factor when you're making a decision about who to treat and who not to treat aggressively.
Who disturbs my slumber?
Now, why our detection strategy is detecting cancers which are latent? The basic reason is that our current methodology is based upon PSA-based screening. And we know that PSA is a prostate-specific antigen. It's not prostate cancer-specific marker. And its value does not always correlate with presence or absence of cancer. So for example, look at this data, and there is no PSA on which you cannot have a cancer. So even at a PSA of 0.0 to 0.5, there is 7% chance of having a cancer and a 1% chance of having a significant cancer, which is ISUP greater than 2 prostate cancer. Similarly, the PSA, which is considered as normal, which is 4 nanograms per ml, there is a 27% incidence of cancer, with 7% of these cancers are clinically significant. So that's one of the major problems with PSA-based screening. There's an interesting paper published in European Urology about 5 years back by Anderson, and they have looked at ISUP grade 1 disease treated by radical prostatectomy. So a cohort of over 2,500 patients. The incidence of extraprostatic extension, which is one of the factors defining how aggressive the cancer is, was less than 0.25%, so almost negligible. Whereas seminal vesicle invasion and lymph node involvement was not seen in any of the patients. So perhaps these patients have been treated by a very aggressive surgical procedure with significant quality of life consequences, and their cancer probably would not have progressed. If you look at the current EAU guidelines, and there are strong recommendations that in men who have a PSA between 2 and 10, and a normal digital rectal examination, you use biopsy not as an automatic decision, but modify your decision based upon use of risk calculator and use of imaging. And the imaging which has really impacted is the multiparametric MRI scan. The use of additional serum and urine and tissue-based markers are currently not recommended in regular clinical practice because the evidence is not strong. So what is this risk calculator? Let's have a look at this risk. So it's one of the risk calculators that I have shown you here. And you can just go on to and look at this on the websites. The characteristic that it requires you is the race, age, PSA, family history of prostate cancer, digital rectal examination findings, prior biopsy, and some of the tests which are not routinely performed, but they can have a significant impact on defining if the cancer is likely to be aggressive. So these include PCA3, the total upon the free PSA values, and the T2ERG, and I'm going to talk about these a little later. So if I put a data of a person who is, say, 56 years of age, his PSA is 1.5, There is no family history of prostate cancer. The digital rectal examination was either not done or the person doesn't know whether it has, what are the findings. Never had a biopsy before. There is only 2% chance of a high-grade prostate cancer. And there is only 12% chance of the cancer itself. So there is an 86% probability that this person does not have cancer. So if this person undergoes a biopsy, he should be informed that the biopsy is not totally inconsequential. It can have significant complications. And about 2 to 4% of men require hospitalization secondary to sepsis or biopsy-related complication. So it's important that one should be cognizant of these things when you're making clinical decision. Now, the two things that we have talked about in that risk calculators was free PSA, which all of you know very well, and risk, which is one of the ways of defining whether this PSA is significant and make a decision whether biopsy should be done or not. The second thing is the two markers, the TMP-RSS2 ERG and the PCA3. Now, the previous data about PCA3 is more for defining the need for rebiopsy. It can be used in this setting as well. Now, this is a prostate-specific and androgen response gene, the TMP-RSS2, and it encodes protein belonging to the serine protease family. The function in prostate in carcinogenesis and relies on gene fusion with ETS transcription factors such as ERG. So TMP-RSS2 gene can couple with ERG, and that can give you an idea if that's present in the urine of a specimen of a patient, there is a possibility of an aggressive cancer. So it is very simple to perform. The RNA is isolated from the urine, and then the gene sequencing is done. The isothermal amplification is performed, and you can just do a visual inspection or detection to see if there are amplicons without flocculation or amplicons with flocculation. The presence of these amplicons basically is an indicator of TMP-RSS2 ERG mutation, and that's an indication of aggressive cancer. It's a pretty simple, straightforward, doesn't require sophisticated equipment, and it's a pretty cheap test to perform. The second thing is the PCA3, which you're all very aware of. An aggressive DRE is performed, the urine is collected, and the urine is then used to detect the PCA3, which is a messenger RNA, non-coding messenger RNA in the urine specimen after a DRE examination of patients having prostate cancer, and aggressive cancers can be detected if is suspected if the PCA3 test is positive. So there is a significantly high overexpression of PCA3 in prostate cancer patients compared to normal and BPH patients. What about imaging, which is considered as one of the tool or recommended as one of the tool by the EAU, that before ordering for a biopsy, one should look at these factors. And this article was published in JAMA Oncology about 5 years back, exactly 5 years back, actually. And it looked at the impact of T2-ERG and PCA3 that we have just talked about. And this question was, that can urinary testing of prostate cancer-associated RNA, which is PCA3 and TMP-RSS2 ERG mutation, improve detection of aggressive prostate cancer, which is ISUP2 plus cancers. They looked at over 1,000 men, and the urinary parameters were assessed. The findings were that urinary testing of both of these can avert unnecessary biopsy with consequent potential of healthcare cost savings. The second parameter that we have talked about is the imaging. in the EAU guidelines. And the EAU guidelines essentially talks about that a prior multiparametric MRI can actually impact the decision about presence of a significant cancer. However, the sensitivity of multiparametric MRI scan is for ISUP grade 2 plus cancers and tumors which are at least 1 centimeter. There are various sequences in multiparametric MRI, and of that, the significant ones are the T2 weighted images and the DWI with calculation of ADC values. And based upon this, the cancers is graded as PI-RAD 1 to PI-RAD 5. The higher the PI-RAD grade, the greater the chances of an aggressive cancer. So PI-RAD 5 is a very high clinical significant cancer possibility. PI-RAD 1 is a very low clinically significant prostate cancer. So if you have a PI-RAD 4 or 5 lesion, there is a significant chances that the person may have a cancer with biological consequences. So these patients should undergo biopsy. So once you diagnose the cancer, the second important step is to see if your cancer, what kind of a biological potential this cancer has. So EAU risk group for biochemical recurrence and locally advanced prostate cancer risk stratification is low risk, and this is based upon 3 things. Number 1, the PSA, the Gleason scale or ISUP grading, and the clinical stage of the cancer. So if you have a PSA of less than 10, if you have an ISUP grade of 1, and if you have a T1 or T2 clinically cancer, that it's a localized disease and it's a low-risk cancer. Intermediate cancer, the PSA is between 10 and 20, Gleason is 2 to 3, ISUP is 2 to 3, Gleason 7, and 3 plus 4 and 4 plus 3. In clinical stage up to T2B. This is intermediate risk, whereas high risk and very high risk and locally advanced prostate cancer includes PSA of greater than 20, Gleason scale of greater than 7 means 8, 9, 10, with ISUP grading of 4 to 5. Clinically T2C cancer, whereas high-risk cancers or locally advanced cancers are the one which is any PSA, any GS, but clinical stage of T3 or T4 plus minus clinically present lymph nodes. So low, intermediate, high, and locally advanced cancer are the 4 categories that the cancers can be put once the diagnosis is made. And we'll see how you make those decisions about the management of these cancers once you have risk stratified them. So for low-risk cancers, there is no need for additional imaging for staging. So, for example, bone scan or MRI scan, if the MRI has not already been done preoperatively or pre-biopsy. For intermediate risk, ISUP grade 3 cancers, at least 1 cross-sectional abdominal pelvic imaging and bone scan for metastatic screening. So in this category, the PSA is greater than 10 and less than 20. Although these recommendations are not very strong, but they're there. However, for high-risk cancer, it's and localized, locally advanced cancer, perform metastatic screening with cross-sectional imaging of the abdomen, which is abdominal pelvic CT scan, and a bone scan. When you're using a PSMA PET scan or whole body MRI scan, it increases the sensitivity, but there is no association of these imaging compared to CT and bone scan in terms of overall outcome and decision-making about the treatment. So generally, PSMA PET or whole body MRI scan is not really recommended at this point in time an abdominal CT, abdominal pelvic CT, and a bone scan generally suffice. Okay, so as we have said that we are overdiagnosing cancers, and these cancers are really some of these cancers will probably not progress. And if they're not going to progress, why subject these patients to the side effects of radiation or side effects of surgical procedure? So some of these patients can be managed, particularly those in the low risk category, almost all of them in low risk category, by deficit management. And deficit management is divided into the watchful waiting and active surveillance, and both are slightly different in terms of how do you deal with these patients during the follow-up. So the difference between watchful waiting and active surveillance is the treatment intent. Number two, how you do the follow-up, what assessment and markers are used during the follow-up, life expectancy of the patient, what is the overall aim of management of these patients. And so if you are doing active surveillance, your intent is curative. So you don't want to intervene when the patient has low risk of an advancing cancer, but you want to intervene if there is any indication that the cancer is advancing. Whereas in the case of watchful waiting, the intent is palliative. So you want not to intervene to decrease the complication rate and try and do things in a palliative manner. The follow-up is predefined in active surveillance, and in watchful waiting, it is patient-specific and at the discretion of the physician treating. You need to do DRE, PSA, MP-MRI, and rebiopsy at defined schedule in active surveillance, where there is no defined schedule for watchful waiting, and you can really do it as at a decision based upon individual patients. The basic difference between these two categories and why you put somebody in active surveillance and the other person in watchful waiting is their life expectancy. Somebody who is likely to live greater than 10 years, has a small volume cancer, a low risk cancer, or even intermediate cancer, and likely to live greater than 10 years, it's possible that if you do not intervene now or intervene at a much later stage, there is a possibility of cancer advancing. So you need to keep them under active surveillance and intervene so that they are safe from the complications of intervention and also not suffer from the advanced cancer disease. Now, how do you define which patient? There is a clinical impression, but then there are various tools available. And these tools are highly recommended by EAU to determine the life expectancy and health status of your patient at a defined moment when you have made a diagnosis of prostate cancer. And these includes the geriatric 8 and mini-COG and clinical frailty scale, and they're all highly recommended by the guidelines. Now, if the score on the G8 scale, the mini G8 scale, is less than 14 or less than 14, then you need to do a full geriatric evaluation, and then you would recommend it to a geriatrician to make that decision about the life expectancy. This is the G8 scale, and it has 7 domains, A, B, C, E, F, H, P. Now, based upon these 8 domains, sorry, age as well as a domain, you score your patient, and it's pretty straightforward, takes about less than a minute to score your patient on this G8 scale. And if the score is less than 14, then this patient require full geriatric evaluation. The deferred management, the other thing is active treatment. On active treatment, you need to inform your patient that based upon a very robust 12-year follow-up data, no active treatment, an active treatment could be surgery or radiation therapy, is superior to deferred management. So that needs to come very clearly in terms of overall and prostate cancer specific survival for clinically localized disease. Patients who are likely to live for less than 10 years should be offered watchful waiting and inform the patients that all active treatment have side effects, be it surgery or be it radiation therapy. So what are the two active treatments and treatment modalities or major modalities is the surgery and the radiation therapy. Open surgical method to do radical prostatectomy, laparoscopic, and robot-assisted. The current data does not show superiority of one over the other, neither in terms of oncological outcome nor in terms of functional outcome. So it's important that person who is performing these procedures is adept in doing that kind of procedure. So if somebody is good with open, he should do open surgical method rather than attempt laparoscopy and robotic assisted. So you make a decision based upon various algorithms, whether this person require a lymph node dissection or not. And if he requires a dissection, that should be an extended dissection. And there is a strong recommendation in this regard. The extended lymphadenectomy means that you go up to the bifurcation of the aorta. Do not perform nerve sparing when there is a risk of ipsilateral extracapsular extension. We know that nerve sparing is important for continence and erectile function preservation. But if you perform nerve sparing, you risk the chances of extracapsular extension or residual disease. So make this decision based upon preoperative evaluation. Never offer neoadjuvant hormonal therapy to a person who is likely to undergo surgery. So this is something which is disastrous. And I've had the bad experience of operating on patients who have had neoadjuvant hormonal therapy, because unfortunately, this is something which happens in this country a lot. So people who are not really treating prostate cancer at a high level, they would start, no sooner they diagnose prostate cancer, they would put them on hormonal therapy. And if subsequently the decision is made about surgical management, it's a disaster. So if they end up receiving medical radiation therapy, that's fine. But if they have to undergo surgery, it is really a nightmare. Once a person has received an active treatment, follow-up is the most important thing, because regular stringent follow-up decreases the chances of complication and cancer spread. So after radical prostatectomy, the PSA should be undetectable, less than 0.1 nanograms per ml. Any PSA rise after radical prostatectomy of greater than 0.1 nanogram per ml is a signal of residual prostate tumor tissue. And that should be dealt accordingly. So if somebody has an undetectable PSA following a radical prostatectomy and develop a PSA of greater than 0.4 nanogram per ml, and it is rising, it best predicts further metastases. So 0.1 to 0.4 is a gray area in which this patient can be managed conservatively, followed up regularly, but once it crosses 0.4 nanograms per ml, there is a high risk of developing a metastatic disease, and a decision should be made about next treatment option. Compared to radical prostatectomy, because the prostate is still there after radiation therapy, the PSA or biochemical recurrence is defined as nadir value, the lowest value achieved after radiation hormonal therapy combination, plus 2 nanograms per ml. So, and this rise above this value. So if the nadir value obtained was say 0.4, and if the person's PSA is more than 2.4, then there is a biochemical recurrence, and this patient should be managed accordingly. If you have a palpable nodule and if you have a rising PSA, this is a sign of local recurrence, and localized treatment is often required in these cases. Remember one thing, that not all patients who have a biochemical recurrence are the same, as these may have probably the same calories, but they are not same in terms of the impact on your health. So not all biochemical recurrence are the same. EAU defined biochemical recurrence as a low-risk biochemical recurrence and a high-risk biochemical recurrence. So if you have a low-risk biochemical recurrence after radical prostatectomy, the PSA doubling time is greater than 1 year. So PSA doubled from 0.1 to 0.2 in after 1 year, or 0.2 to 0.4 after 1 year, then it's a low-risk disease. And if the pathological grade of radical prostatectomy specimen was less than 4 ISUP. Following radiation therapy, the interval to biochemical failure of greater than 1.5 years is considered as a low risk. Again, if the biopsy is ISUP grade 4. So if you have these characteristics, this is considered as a low-risk biochemical recurrence, and high-risk biochemical recurrence is an opposite. So the PSA doubling time after radical prostatectomy is less than 1 year, or the pathological grade is 4 to 5. Similarly, the same opposite for radiation therapy. So what are the recommendation of second-line therapy after treatment with curative intent? So whatever you have done in terms of curative treatment, like radical prostatectomy or radiation therapy, you now need to make a decision after biochemical recurrence that what would be the next line of action. So if somebody had a radical prostatectomy, the biochemical recurrence, which is high risk, early salvage IMRT plus IGRT to men with 2 consecutive PSA rises is strongly recommended. If there is a negative PET scan, one should not delay radiotherapy if otherwise is indicated. Salvage radiotherapy, that's what I meant. Do not wait for PSA threshold before starting treatment once the decision for salvage radiotherapy has been made. Typically, it is 64 gray and should be given as soon as possible. The role of hormone therapy at this stage, however, is not very well defined. What after biochemical recurrence following radiation therapy? Monitoring is advised, including PSA to low risk, EAU low risk biochemical recurrence. For high risk biochemical recurrence, salvage radical prostatectomy, brachytherapy, or use of some of the other modalities like HIFU or cryosurgery. And these are particularly in highly selected patients with biopsy proven local recurrence is what is recommended. If you do not have evidence of a systemic disease or a metastatic cancer, and the patient has a PSA doubling time of greater than 1 year, do not give any hormonal therapy. Now, what about treatment of the locally advanced disease? Well, the radical prostatectomy is only offered to a very select group of high-risk locally advanced prostate cancer, and particularly in the setting of multimodal treatment, which means that this patient is likely to need hormones as well as radiation therapy after radical prostatectomy. These patients should undergo, if they are having radical prostatectomy, they should undergo extended lymphadenectomy. There is no point doing a frozen section, as these patients are likely to require adjuvant treatment in terms of radiation and hormones anyways. Radiotherapy, again, is the preferred mode of treatment in such situation, and the ADT should continue for up to 3 years, 2 to 3 years in most of these patients after radiotherapy. Therapeutic options beyond the radiation and surgery, the focal therapy again is not recommended, and ADT monotherapy is again also not advised in such situation. Well, as I've said, that the EAU guidelines are clear about the other treatment modalities like HIFU, etc., but there are no strong recommendations. Okay, so coming to this last point of this presentation about post-RRP adjuvant radiation therapy. So you have an RRP performed, and decision is needed about whether this person requires adjuvant treatment, not as salvage radiation, but adjuvant treatment after your radical. So this is typically based on adverse pathological features, which means that grade 4 to 5, which is Gleason 6, 9, and 10, with a greater than T3A stage or lymph node invasion. These are the adverse pathological features on which these decisions are typically made. However, it's important to remember that not all patients with these adverse pathological features behave the same. So again, you can tailor the treatment with adjuvant radiation therapy in a more defined manner. So it's not necessary that all these patients with an ISUP 4-5 or T3A greater than T3A disease with lymph node involvement should receive radiation therapy. So this is an interesting paper published in the Journal of Urology very recently. In fact, when I was making this presentation about a few weeks back, it wasn't published in full form. So it is a very recent paper looking at over 8,000 patients' data between 1987 and 2020, and of which nearly 1,000 patients were eligible with further analysis because they had adverse pathological features. These patients, the authors classify them into low, intermediate, and high risk categories. And to define whether adjuvant radiation therapy is needed in all these three categories or not. So patient with adverse pathological features, meaning ISUP grade 4 and 5, clinical T3A disease, were 881 patients. And based upon various other parameters, they have been, and these parameters is whether the disease is T3A or T3B, and on which you can give 0 or 1 point, whether grade was 4 or 5, whether the node were positive, and if they were positive, then whether 1 to 2 nodes were positive or more than 2 nodes were positive. And based upon these, they were classified into high risk, intermediate risk, and low risk category. If we look at the Kaplan-Meier curves of survival of these patients with low-risk group, patients who were treated with adjuvant radiation therapy, or they were only treated by observation and salvage radiotherapy, they had the same survival. Meaning that if you are in the low-risk category, with 0 to 1 point, which means that you have a T3A disease, you have grade 4, and you have no node involvement, then you probably do not need adjuvant radiation therapy. And these patients can be managed by observation plus salvage radiation therapy, meaning radiotherapy given at a certain point in time when their disease starts to progress. Okay, so no difference. So there is no need for adjuvant radiation therapy. If you have an intermediate risk group, again, observation and adjuvant radiotherapy have same survival. So there is no difference between the survival of patients in the two categories. 92%, both. It's a 10-year survival. However, if you have a high-risk category, which means that you have T3B disease, you have 2 nodes greater than 2 nodes positive, you have grade 5 ISUP cancer, then adjuvant radiotherapy is important because, as you can see, within the first 3 years, these patients have a significant difference in their survival. So the Kaplan-Meier curves start to move apart in the two groups between observation and salvage therapy versus adjuvant radiotherapy. So if you are in the high risk category, you should receive adjuvant radiation therapy earlier than later. So in summary, the risk stratification is extremely important, and indication for biopsy using the risk calculators and imaging modalities are of utmost importance. The therapeutic options have significant side effects, so they should be offered with caution. There is no significant difference in the functional and oncological outcome with open, lab, or radical-assisted radical prostatectomy. All locally advanced and most high-risk patients with require multimodality therapy. So surgery itself does not suffice. You need to have radiation plus hormone in majority of these patients. Patients who have had a radical prostatectomy and have adverse pathological features, they do not behave the same way. So it's important that you risk stratify them into low, intermediate, and high risk before you make the decision about adjuvant treatment. And also, not all biochemical recurrence are the same. So risk stratification between low risk BCR versus high risk BCR is important. And so that's why it's important that one should be able to make these decisions based upon the current guidelines, based upon the current literature. And so these make the basis for clinical decision-making in the management of localized and locally advanced prostate cancer. Thank you very much for your attention.